So let's talk about the natural history of atherosclerosis. As all of you know, there are systemic factors: hyperlipidemia, diabetes, smoking, hypertension, age and sex, and PLA2, CRP, all have been implicated. But I think there are also local factors at branch points, that is carotid bifurcation, abdominal aorta just above bifurcation, and coronary artery branch points, arch vessels that take off, are the sites of atherosclerotic manifestation. And thrombosis in the coronary arteries occur at focal points. They don't occur diffusely, and is most often located in the proximal portions of the three main coronary arteries. And these sites have extensive underlying plaque inflammation in the fibrous cap and areas surrounding the necrotic core, and I'll address some of these, how they lead to stent thrombosis. As you all know, we pointed out that there are three main causes of coronary thrombosis, most common being plaque rupture, which occurs in about 70% of cases, second most common being plaque erosion. In 50% of cases, there's no underlying necrotic core, but there is a surface thrombus. And in others, about 50% will have a necrotic core, but does not communicate with the lumen, and there's a luminal thrombus. Whereas calcified nodule occurs in about 2 to 5% of cases, more common in carotid than in coronary arteries. Now, the natural history of coronary atherosclerosis as yet is poorly understood. It is all based on autopsy cases and our understanding as age advances, what do we see? As you can see here, intimal thickening, which is the adaptive mechanism, occurs in all at birth. About 30% of infants are born at branch points to have intimal thickening. By 6 months, everybody has that intimal thickening at branch points, which is called as adaptive thickening. Then fatty streak is the lesion which was early recognized as the earliest lesion of atherosclerosis, which I don't believe is the early, as we know that this lesion can regress, that is intimal xanthoma can regress. I believe the earliest lesion is pathologic intimal thickening, where there are underlying lipid pools and may or may not have luminal macrophage infiltration, and I will address that in a moment. Of course, fibrous cap atheroma is the lesion best recognized, which is the necrotic core with an overlying fibrous cap, which is thick. And the lesion that we have described as a precursor lesion to plaque rupture is called as the thin cap fibroatheroma, which has an underlying necrotic core, and a fibrous cap, which is less than 65 micron in thickness and is infiltrated by macrophages and T cells. So let's talk about adaptive intimal thickening. As I said, can lead to fatty streak macrophage infiltration, which is the fatty streak or intimal xanthoma, and these lesions can regress, although not always. Pathologic intimal thickening, we believe, is the earliest lesion and is responsible for being converted to fibroatheroma, which we have classified further into early fibroatheroma and late fibroatheroma, and I will address those. And of course, there's the thin cap fibroatheroma, which goes on to rupture and lesion enlargement occurs, and this could occur either asymptomatically or symptomatically. So inflammation plays a primary role in the progression of human atheroma. The key role of inflammation in atherosclerosis is evident in many epidemiological studies, indicating an association between inflammatory markers such as CRP, interleukin-6, oxidized LDL, and risk for cardiovascular events. PLA2 is a novel inflammatory marker that has been recently a focus of a large number of epidemiologic studies showing that plasma levels predict cardiovascular events. PLA2 messenger RNA and protein have been detected in macrophages in man and in rabbit non-coronary atherosclerotic lesions. So in PLA is a secreted protein. It is calcium-independent serine lipase that is predominantly associated with low-density lipoprotein as much as 80%. PLA2 is produced by circulating and tissue monocytes and macrophages, as pointed out, and its molecular weight is 45 kD and binds to the C-terminal with ApoB on LDL. Of course, its chromosomal location is also known. The PLA degrades platelet activating factor, hydrolyzes oxidized phosphatidylcholine, oxidized LDL, generates the lyso-PC and oxidized fatty acids, two components that are pro-inflammatory products that contribute to the formation of atherosclerotic plaques. We know that the LPPLA2 oxidizes the LDL to release pro-inflammatory cytokines. Here is phosphatidylcholine. You can see oxidation leads to oxidative modification of PC, and this, in the presence of LPPLA2, leads to the formation of oxidized fatty acids and the lyso-PC, which are both toxic to the vessel wall and to cells. As shown here in this diagram, you can see that the way the LDL comes, the LPPLA comes through the LDL, which is internalized, which activate the endothelial cells, leading to monocyte adherence. And this monocyte adherence then leads to internalization of monocytes. The extracellular matrix also binds the LDL, which gets modified, and oxidized PC is released. In the presence of LPPLA2, again, leads to lyso-PC and oxidized non-esterified fatty acids. These are toxic to the macrophage monocyte or to the macrophage foam cell, and this leads, in the presence of LPPLA2 and also in CD34 activated, this leads to apoptosis of the macrophages, and LPPLA2, that's oxidized PC, leads to this apoptosis, and this, and I will address this in a moment, saying that the efficacy of the monocytes, also macrophage monocytes, makes a difference, whether they can internalize those apoptotic bodies or not, how the necrotic core enlarges. We, some time ago, in 2006, showed that the LPPLA2 expression in plaques, whether it be pathologic intimal thickening, thin cap fibroatheroma, and plaque rupture, that these increase as the plaque progresses. As I showed you, from PIT it goes to fibroatheroma to thin cap fibroatheroma, and eventually to rupture. And as shown here, the LPPLA2 expression within the plaque also increases. So sites of LPPLA2 staining in various lesions. In pathologic intimal thickening, the staining is minimally detected in the intimal smooth muscle cells and macrophages. However, in fibroatheromas, LPPLA2 staining was exhibited in macrophages, especially those within and surrounding the necrotic core, and LPPLA2 in intimal smooth muscle cells is much less. In thin cap fibroatheroma and ruptures, LPPLA2 is highly prominent in macrophages in the fibrous cap that are undergoing and forming the necrotic core. The LPPLA2 expression in stable and unstable carotid plaques, we looked into it, consecutive cases, and asked the question in a total of 78 plaques that are there expression in stable, and what is the difference between stable plaques and what is the difference in those which are not stable. And stable were defined as those classified as fibroatheromas, heel plaque ruptures with or without nodular calcification. Unstable plaques consisted of thin cap fibroatheroma with or without ulceration, and ulcerated or non-ulcerated plaque ruptures with organizing thrombi. These are the total number of cases that were stable, that is 42. Unstable were 36 cases. And what we did, we asked the question, how much is CD68 expressed? That means how many macrophages are there. And as you can see in stable plaques, much less as compared to unstable plaques. There are many more. And if you look at LPPLA2 expression, is significantly less in the stable plaque as compared to the unstable plaque. And of course, these are significant. Here's the data shown again. We also looked at in stable and unstable plaque, looking at necrotic core over plaque thickness, and we showed that the ratio was much greater in those in the unstable plaque as compared to stable plaque. Similarly, as shown earlier, macrophages are greater, and LPPLA2 expression is also greater. Here are plaques showing thin cap fibroatheroma. You can see here necrotic core, thin fibrous cap, you can see macrophage infiltration, and you can see the expression of LPPLA2. In plaque rupture, similarly, looking at this fibrous cap, you can see macrophage infiltration, and you can see expression of LPPLA2, although less than the total number of macrophages that are there. If you look at fibroatheromas in stable plaques, which have a thick fibrous cap, you can see LPPLA2 expression within that necrotic core, probably related to the formation of the necrotic core through the macrophage formation and its cell death. In fibrous plaques, you can see there is hardly any LPPLA2 expression. So what I've shown you is immunohistochemical detection against LPPLA2 revealed that the protein expression was mainly within macrophages and associated extracellular matrix, while fibrous regions showed little expression of LPPLA2. There was a relative increase in necrotic core to plaque thickness in the ratio in unstable versus stable plaques. Fibrous cap areas showed positive staining for LPPLA2 and was significantly greater in unstable versus stable plaques. Similarly, areas within the fibrous cap also showed greater CD68 staining for macrophages in the unstable plaque. So the necrotic core, we believe, is the graveyard of dead macrophages. This has been shown by Ira Tabus. And the necrotic core forms from the inflammatory cells, probably coagulation factors, proteases, and stress within the fibrous cap all play a role in leading to plaque rupture. Now, we think there is the mechanism of necrotic core progression occurs from early to late. And how does it occur from early to late? Pathologic intimal thickening areas, that is lipid pool areas, get infiltrated by macrophages. These macrophages undergo cell death, apoptosis occurs. However, there are surrounding macrophages that will engulf the apoptotic bodies, and this is a highly efficient system in the early necrotic core, but not so in the late necrotic core. There are lots of apoptotic bodies, and no longer is endocytosis or engulfment possible by the macrophages, so therefore that leads to necrotic core and high expression of CD68 in that necrotic core. We also believe that hemorrhage plays a very important role, and free cholesterol tends to come from red cell membranes, and I won't address this in this. So overall, if you look at early necrosis, engulfment, foamy macrophages undergo via the ER stress. Clearance of the phagocytes occurs through efferocytosis. The defective engulfment has been shown in late necrosis occur from excessive foam cell apoptosis, and there is defective efferocytosis, and these are the various ligands involved. And of course, hemorrhage also gives rise to free cholesterol, free hemoglobin, macrophages, and decreased efferocytosis. So this is one of the papers which came from Belgium, and it's a very nice study. What they did was they looked at phagocytosis efficiency of apoptotic cells. What they did, they compared it to tonsil and atherosclerotic plaque from the carotid. And they looked at carotid plaque, tonsil here, the red marks the tunnel staining, and CD68 is marked by the blue staining. And what is here, if you look at percent apoptotic cells, and if you look at the tonsil, the free apoptotic cells are very few, whereas there are many more free apoptotic cells in the atherosclerotic plaque, thus showing inefficiency in the atherosclerotic plaque. If you look at the uptake, it is much greater in case of tonsil as compared to atherosclerotic plaque, thus showing that the efficiency, again, is better in tonsil as compared to the plaque macrophages. And if you looked at one apoptotic body, 2 or greater, and if you look at one apoptotic body, are much greater in the atherosclerotic than in tonsil. However, if you look at the efficiency, that is more than one apoptotic body is taken up, you see the efficiency is much greater in the tonsil than in the atherosclerotic plaque itself. So what we did was we wanted to ask the question, is pathologic intimal thickening where there are no macrophages? What is the expression and how much are there macrophages in pathologic intimal thickening plus macrophages, early necrotic core and late necrotic core? And you can see we've looked at plaque area, that it increases as the plaque progresses. Same way percent stenosis increases. If you look at necrotic core, essentially you see them only in early and late necrotic core. And if you look at macrophage increase as plaque progresses. If you look at apoptotic cells, these also increase as plaque progresses, and I won't address vasovasorum. So this is to show you various plaques as shown here. You can see macrophage infiltration. You see in these macrophage infiltration as well as in early necrotic core, and it tends to occur more towards the luminal side, these macrophages. And late necrotic core, you can see that it is throughout, that CD68 positivity is seen throughout. And if you look at DNA fragmentation, look at the DNA apoptosis, you can see it much less in PIT, followed by PIT with macrophages, essentially only occurring in the area of macrophages. And this markedly increases once we see fibroatheromas, and especially in late fibroatheromas as shown here. We also know, if you look at the matrix that is there, that is hyaluron and versican are expressed in that early fibroatheroma, that is when the macrophages are coming and digesting this hyaluronan and versican. And if you look at late necrotic core, these two matrices are no longer present, and there is no matrix in the area of the necrotic core. We can also show you the expression of oxidized LDL. We did this work with Sam Samikas in collaboration with him. The antibody was provided by him. And if you look at oxidized EO6, this antibody, you can see the expression. It essentially only there when you see early necrotic core, late necrotic core, and thin cap fibroatheroma highly expressed. Same time as I will show you that we also see LPPLA2 expression. So if you look here, you can see macrophage increase, fatty streak with or without macrophages. And you can see PIT with macrophages, early necrotic core, and late necrotic core. And you can see the LPPLA2 expression increases, although it is also seen in fatty streak. We don't understand why it regresses in some places and not in others. That needs to be investigated further. I just want to show you some of the cases that we've seen. Pathologic intimal thickening. You can see there are hardly any macrophages and there are hardly any tunnel positivity. And LPPLA2 is sparsely seen in smooth muscle cells. However, as soon as we see macrophages, we see a large amount of LPPLA2 expression, macrophage present, LPPLA2 expression, and we can show you tunnel as well as macrophage positivity occurring only at the sites where there is macrophage cell death occurring. Again, looking at early fibroatheroma, macrophage, LPPLA2, and again, looking at tunnel positivity, the red areas represent the tunnel positive areas. Late fibroatheroma, you can see the coexistence, you can see LPPLA2 expression and large amount of macrophages. And co-expression of LPPLA2 with apoptotic macrophages in early necrotic core, you can see here as shown here, you can see large number of red, which is the tunnel positivity, large number of macrophages undergoing apoptotic cell death. So in summary, what I've shown you in lesions characterized at pathologic intimal thickening with minimal presence of macrophages, there is minimal expression of LPPLA2. In pathologic intimal thickening with macrophages, there is increased expression of LPPLA2 with early evidence of macrophage apoptosis. Macrophage foam cell expression, LPPLA2, are commonly found in regions bordering the necrotic core and fibrous cap, where the level of apoptosis increases with plaque progression from early to late necrotic core. Plaque rupture and thin cap fibroatheromas show the highest expression of LPPLA2 and is seen in both coronary and carotid plaques. Dual immunostaining confirms the co-expression of LPPLA2 occurring in macrophages. So in conclusion, LPPLA2 is likely an important marker for the presence of unstable plaques in coronary and carotid plaques. The presence of LPPLA2 within plaques correlates with macrophage apoptosis, and its expression increases with plaque progression. Thank you so much.